Good afternoon. I'm Sandy Lozo, RCMA's Practice Support Liaison. Thank you for joining us today for Violence in Healthcare Problem, Preparation, and Response webinar presented by ProAssurance. ProAssurance is RCMA's endorsed professional liability partner, so when it's time to renew your coverage, please be sure to reach out to ProAssurance for a competitive quote for your practice. Our speaker today is Katie Theodorakis, who is a regional manager with ProAssurance. Katie has over 20 years of experience in the professional liability field, providing consultation services to hospitals, physicians, and clinics on a multitude of risk management topics. She's been with NorCal and now ProAssurance since 2002. Welcome, Katie.
Thank you so much, everyone, for joining this afternoon. And one more big thank you to Riverside County Medical Association for hosting this webinar today. We really appreciate it, and it is a very important topic, so I'm so glad that you all can join. The one thing I just wanted to start off, as Sandy mentioned, I've been in healthcare a long time. I actually started in 1996 at San Francisco General Hospital, and then I started at NorCal, which is now part of the ProAssurance family, in 2002. And I always say, no matter what topic I'm talking about, that a lot has changed over the years. A lot has stayed the same. One of the biggest things that I would say has changed drastically is the amount of difficult, challenging patients, unfortunately. I think this is something that you probably all struggle with, and that's why I think it's good to have webinars such as I'm doing today, and then also the many, many other courses that are out there and trainings on de-escalation, how to handle these situations. So again, thank you for joining me. Just to briefly talk about our objectives, you see them here: identifying and responding to violence in the healthcare setting, and develop processes to support physical safety measures and implement strategies to promote patient safety, protect physicians and others, and minimize your risk of a professional liability claim stemming out of an incident. Because I think it's important to remember that you all do have a duty to your staff, to yourselves, to your staff and patients, to not to expose them to unnecessary risks. So when I talk about legal actions, those are the type of actions that can stem from a workplace violence incident. I do need to start off just with a little disclaimer that the information I'm providing is to be considered risk management advice, not legal advice. And if you need legal advice about a particular situation, it's always best to consult with an attorney. There I am, and my coworker, Shirley Armenta, who's our CME administrator. And just for CME purposes, I do need to state that neither myself nor Shirley have any relevant financial relationships that I need to disclose to you all. And you will, speaking of CME, you will be or are eligible for 1 hour of CME credit for attending today. And there will be a evaluation survey that's emailed to you at the end of the webinar. And if you just fill that out, then you will be emailed a CME certificate within a day or two. Okay, so I wanted to start off with a fairly recent law that went into effect in California in July 1st of this year. And the law may be applicable to some of you, so I'm going to review it briefly just at the start here. So who does the law apply to? Well, basically the law, it's not just for healthcare. It applies to all employers in California with a few exceptions. And it exempts licensed healthcare facilities, including hospital-based outpatient clinics and other operations located at a health facility, and all off-site operations included within the facility license. And these facilities aren't exempted because they're immune to workplace violence. That's very much not the case. But it's because they already are heavily regulated in this area, pursuant to a separate regulation, a regulation of the Code of Civil Procedure. And so those regulations impose all these requirements on health facilities. So they're kind of ahead of the game in this area. There's two more situations where this new law doesn't apply. It applies to companies that have employees teleworking or telecommuting from a location of the employee's choice, usually home, which is not under the control of the employer. Also exempt are places where there's 10 employees or less working at a place that is not accessible to the public. So that's kind of a big one there. You might have a small office, small staff, but as long as you are accessible, then these new laws apply to you. And a lot of even if this law does exempt you, there's still a lot of OSHA requirements in place that do cover some of this. But for all of you that might not fall into these exemptions, I'm just going to go over the details of the law. It starts off with just a definition of workplace violence, physical force, and also including threats of physical force, use or threat of a firearm or other dangerous weapon. And it's important to note in this definition that the threats don't have to be in person or even on the phone. They can be communicated through text, social media platforms, emails, other online platforms. And this is really important because, as I'm sure you all know, in this day and age, so much of these threats and obnoxious messages are communicated through social media, whether it be Twitter or direct messages, whatever it may be. So those are also included. It does not have to be in person or on the phone. Just to let you all know, I'm been fighting off a cold for about 3 days. So if you hear me taking a sip of water, that's just to avoid a coughing attack. So I apologize for that. I'm just trying to be proactive. The new bill, what are the requirements of this bill? Well, they'd require an employer to establish and implement and maintain an effective workplace violence plan. You also would need to create and maintain a log of incidents for every workplace violence incidents, and you take information from the employee that it happened to. You want to get witness statements and any investigative findings that you do. If there's multiple employers at a work site, then you'd want the employer to give a copy of the log to what they call the controlling employer, which I kind of envision that, say if you have a medical practice and there's a lab on site that's a different owner, then the lab, if there was an incident, they would want to give a copy to the practice since they're kind of encompassed within the practice. The bill also requires training for employees on workplace violence and also requires them to do additional training if, say, something new comes up, there's an unrecognized hazard, or when changes are made to the plan. That kind of goes without saying, you'd want to update them on changes. And lastly, the bill has certain record keeping requirements, including you have to keep records of hazard identification, evaluation, if you correct a hazard, if you do training or when you do training, you have to keep records of all of the trainings and maintain that record. And then also you want a record of all your incident logs, and you have to keep all of these for a minimum of 5 years. You have to maintain all those records. But let's just briefly, I mentioned earlier at the start about how I personally have seen things changed in the healthcare landscape when it comes to violent incidents, workplace violence. But we'll take a look at some statistics that are really going to, I think, hit home and show how large a problem workplace violence is in healthcare. And I hate to start off with these headlines just pulled from the news, but this unfortunately is the reality in which we're living. Start in June of 2022 in Oklahoma, a patient fatally killed his doctor and 3 other people. He blamed his doctor for his ongoing back pain. In May of 2023 in Atlanta, a patient opened fire in a waiting room, killing 1 and wounding 4 in a medical office building. And this patient had a history of mental illness and purportedly was really upset just because he missed his appointment due to being late, and they probably had to reschedule him. In July 2023, a longtime patient, schizophrenic, fatally shoots an orthopedic surgeon in Memphis. So I know these are horrible, extreme examples of violence in healthcare. And violent acts such as this, thankfully, don't occur often. However, healthcare workers, they face intimidation, threats of violence, and just frankly, nasty individuals on a daily basis. So it's important that we look at this topic. Here are some recent labor statistics that just show how many of you there are and how many of you are could possibly be affected by the epidemic of violence. 14.7 million workers in the healthcare industry. And you could see that includes everyone from physicians, advanced practice professionals, nursing assistants, and you're approximately 9.3, almost 10% of all US workers. And 8 out of the 10 workers in healthcare are women. A few more statistics just show the prevalence of violence in healthcare. One sobering statistic, 1 in 5 healthcare workers encounter physical abuse at work, and verbal abuse is even more common. So you can see, as I mentioned, you all make up about 10% of the entire workforce, but experience almost half of injuries due to workplace violence. Another disconcerting statistic is the fourth bullet there, which talks about, or it states that only 1/3 of violent incidents are actually reported. So as you can imagine, it's most likely that the problem is even larger than these statistics show. This was a poll taken by the MGMA, the Medical Group Management Association. If you're not familiar with the MGA, it's a nationwide association made up of practice administrators and leaders in the US. It's about 60,000 members strong. And this poll was taken, it was right after the new year, beginning of 2022. So it was looking back on 2021. And you can imagine in 2021, there was many practices that were still in the throes of COVID and having to deal with the COVID rules and all of that, which tends to upsets people. So you'll see how this poll showed those effects. 71% of the MGMA members said that there was an increase in disruptive behavior. And you can see we're still feeling those effects today. And the respondents reported a number of issues that contributed. And again, you could see the effect of the pandemic on patient behavior. These were some of the reasons cited: refusal to wear masks, refusing COVID tests, submitting to screening procedures, upset about visitor policies, frustration about waits. Nothing really new here. And of course, several of these factors, many of them you don't have to technically deal with today. But I just know anecdotally from the number of phone calls that we received to our risk management helpline about disruptive patients and how to handle these patients, that this number of disruptive patients is still extremely high. So if we take out the COVID-related factors about mask wearing and testing, what are some of the contributing factors that lead to these angry, disruptive patients and potentially violence in the workplace? So if there's a short paragraph that kind of sums up the current situation and hits on some important points, I saw this and I said, that's just a really good summary paragraph from the American Association of Medical Colleges. And this was just from 2 years ago. And I'll just read it. The reasons for the aggression vary: patients' anger and confusion about their medical conditions and care, grief over the decline of hospitalized loved ones, frustration while trying to get attention amid staffing shortages, especially nursing, delirium and dementia, mental health disorders, political and social issues, and gender and race discrimination. So you can see that hits on so much in one paragraph. And again, I know from not only my work and phone calls that I get at work, but also surprisingly have quite a few friends who are nurses. And the stories that I hear from them and what they have to deal with, this paragraph is so true and really hits home. So first, let's take a look at some of the patient care factors. I don't need to tell you, communication in healthcare has always been challenging. Dealing with patient interactions, it's always required the use of effective communication skills, arguably more important now in this current environment than ever. The most common issues: misunderstandings between staff and the patient/perpetrator, followed by unmet needs, unmet service needs, or maybe the patient thinks that they're getting poor customer service. And lastly, communication barriers, they can occur for a number of reasons, such as cultural barriers, language barriers, or barriers due to poor health literacy. All of these can be taken into account. This slide talks about clinic factors, and it refers to clinics and basically outpatient facilities. And these factors mentioned because they tend to apply more to outpatient facilities than hospitals. Many hospitals have security and protective measures in place, locked doors, certain barriers, and in some cases, metal detectors before you can get inside. Many clinics and outpatient facilities are facing long wait times due to overcrowding and staff issues. And of course, there's overcrowding and long wait times at hospitals too, but again, hospitals tend to be better equipped to handle them. And the most often crowded place in a hospital is the emergency room. And emergency rooms tend to have pretty tight security, often stationed right there in the room, and they're ready to assist when needed. That certainly doesn't exempt emergency rooms from violence, but it definitely helps get the situation under control faster. Moving on to organizational factors, insufficient screening of employees. I tend to think offices tend to be really good at this when you're screening employees thoroughly and including background checks and all of that. But we're still finding sometimes that's lacking in some areas. Lack of training, once you do hire someone, that can be a huge factor in workplace violence prevention picture. And I'm going to discuss training in a lot more detail later on in the webinar. These days, staff shortages, lower staff levels, lots of turnover, that can create a very stressful, intense environment. So, when possible, keep those breaks on schedule to give people time to decompress, helps improve staff morale, and helps diffuse stressful situations. Sometimes if there's a situation that's happening, take people out of the situation. Say, if you're a practice manager or physician, step in and try to de-escalate the situation and let staff have a break. Because I know often from my experience talking to staff and practices is sometimes patients will be just horrible to staff and be frankly just mean and say horrible things. And then when they get in the office or in the room with the physician, they're just as sweet as pie. And I know that can be very frustrating for staff. I'm sure you've all witnessed or experienced that. Unconscious bias. Most of us carry around some degree of unconscious bias. I mean, we're human. It just happens when we interact with other people. And as the name implies, we don't intend to carry around these biases. It's not purposeful, but these biases do affect interactions with patients. The biases might be related to certain patient populations, cultures, nationalities. Even a patient's physical appearance may trigger an unconscious bias. You may treat an obese patient differently than a patient who is more fit and healthy. So no matter what, if patients perceive they are being treated differently, it may trigger inappropriate behaviors. Let's talk about patients themselves. So being sick oftentimes is scary, and not understanding what's going on with yourself, that can lead to bad behavior, just those internal stressors. Mental illness, illicit drug use, demanding pain medication, even when it's not appropriate, and these can all create less than ideal situations. And lastly, there's situations where patients are making demands, such as they want a disability form filled out, leave from work. And if these demands aren't met, because the physician is never forced or should never be forced to sign these if they don't agree with what's on the form, then that can create some very confrontational situations. And I know when I worked at the hospital, I had to deal with a couple of these. It happened fairly often, particularly in, say, orthopedics, where we would see that a lot. And last contributing factors, these all have to do with employee-involved violence. And you can have your disgruntled employees who were laid off, terminated due to a poor performance review. Some employees might have conflicts with coworkers, different personalities, sometimes just clash. And something that the employee is going through personal problems, whether it's dating or marriage problems, maybe financial concerns, emotional problems, and substance abuse. All of these factors really can contribute to sometimes a patient just pushing an employee over the edge, and that can lead to violent acts. So I'm going to play a video clip. It's a short clip from Dr. Christine Lajeunesse, and she is located in Reno, Nevada, and she's going to describe a situation that happened to her and her urology practice several years ago. And it involved a patient who had had a vasectomy many years earlier by not even by Dr. Lajeunesse or her colleague who was in the office on that day. It was by a different colleague. But this patient had undergone a vasectomy and for whatever reason became convinced that everything bad that happened in his life was due to this vasectomy. And so he just harbored this resentment and frankly hatred towards this urology practice, and it led up to the situation that Dr. Lajeunesse is going to describe.
This history of believing that all of his problems in life were related to his vasectomy. He'd also lost his job. He was in his mid-50s. It was the recession, and he couldn't find another job. He'd had a girlfriend or a fiance that hadn't worked out. And so all the problems in his life, all the lack of enjoyment of life, he blamed on the vasectomy. And he took some firearms, drove from his house 2.5 hours, 3 hours to the office, came into the office, and when he came in, he was wearing a big overcoat under which he hid all of his weapons, came up the stairs to the 3rd floor, opened the door, and actually had taken off his overcoat sometime before coming into the waiting room, and came in with this gun in his hand and announced to everyone there that he had no problem with them, but that he was going to start shooting and that they should get out if they didn't want to get injured. And he said the same thing to our staff, the receptionists that were there, who thankfully were able to leave. And he then walked through a set of double doors that we have that did not have any kind of security. So he walked through there, came into the back, and stood in an area waiting for a physician to come out. And he just kind of sat there cradling his gun. And the first physician he encountered was me. And he started yelling about ruining his life and how he was going to make us pay. And he shot me. Then he went on to look for another target. He then saw a partner of mine coming out of an exam room, and he shot at that partner. The bullets went through the door and hit the mother of a patient. And then he shot again at my partner, who unfortunately was hit, and he died at the scene.
So Dr. Lajeunesse shared her story in, again, a horrible, tragic situation that I hope none of you ever have to experience. But I was curious about Dr. Lajeunesse after I saw her video that she had done for us several years ago. And she, such a remarkable woman, and she basically said, there's no way that I was going to let this man defeat me and ruin my career and my life. And she bravely went on with her life and spent some time educating. And I'm going to play another clip in a little bit where she talks about, in hindsight, some of the security measures they might have had in place to prevent that tragedy from happening. Okay, so let's talk about, now that we've heard that horrible story, let's talk about some prevention. techniques. So reducing healthcare violence in healthcare, it really requires the development of a plan, a comprehensive violence prevention plan. And it's really important to obtain buy-in from administration and physicians, because it, as with a lot of things, it really trickles down within the office, and commitment to the plan has to start up at the top. You can get involved, local law enforcement, other security groups in the area. Oftentimes they have valuable information and really helpful resources in developing these violence prevention plans. Reaching out to others in the community to see what others have in place, particularly if you work close to or even with, a large healthcare system, because they already have plans in place, and I'm sure would be more than willing to share with you what they have in place. And then you'd have to adapt it, of course, to meet your particular situation. Check out some potential physical security measures. And a lot of this will have to do with what's appropriate, again, for your particular situation. But you can do video cameras, silent alarms, panic buttons. I'll just share, back in the day when I first started in risk management at San Francisco General, our risk management office was in a separate building than the main hospital, still on the hospital campus, not that far away, but we were kind of off by ourselves in this separate building that, we were kind of secluded over there. And we oftentimes were called in to deal with upset patients. And we usually would try not to meet the patients in the office. We would go over to the main hospital and meet maybe in the patient advocate office. But sometimes patients would track us down and come to our door. And I did have a panic button under my desk in case I needed it that would immediately call security. And security was nice. They were very protective of us because they knew we were kind of secluded and had to deal with difficult situations. Thankfully, in my 4.5 years there, I never had to use that panic button, but I could tell you, just knowing that it was there, I felt safer knowing that I could trigger security at a moment's notice to come help. And locks on entrances, locks on doors. All of these are things to consider just to prevent that easy access. And if you can't, even if a lock, say, can't completely block a perpetrator, it oftentimes will slow them down and buys time for others to seek safety. And then an important part of a plan is to conduct a risk assessment. You need to find out, it's hard to implement security measures when you don't really know what the risks are. So just looking at your entire premises and doing a risk assessment. When appropriate, screening of patients, visitors, vendors. It used to be back in the day that reps, like pharmaceutical reps or whoever, would just be able to wander all around offices and no one really stopped them. And in those days, of course, we don't see that anymore. So just reducing access to certain areas where people should not be allowed to just come in anytime they want. And lastly, having clearly defined exit routes so someone can easily get to safety in the quickest way possible if necessary. And I was just going to pause for a second because I just want to make sure I didn't see my chats before. Okay, great. It was just Sandy posting things. So I just wanted to make sure that I wasn't missing a question. As Sandy mentioned, if you do have any type of question or comment, please feel free to put it in the chat. I might not be able to get to it in the hour, but I know Sandy and everyone at RCMA is so great about providing that information to me, so then I could just email you. I can get you out an answer to your question if I can't do it live. Oop, there we go. Okay, I mentioned earlier that I was going to talk a little more detail about staff training because it's such a critical part of workplace violence prevention. And an important part is just training them to recognize behavioral signs that something bad might happen. Verbal, physical threats, that's kind of obvious. Escalating voice levels, abusive language, discussion of weapons, should that ever come up. And you need to ensure that staff members understand how to appropriately communicate to others within the office and what to do if a situation is occurring. And Dr. Lejeunesse is going to talk about that strategy a little bit more when I play her remarks on prevention. Staff should remember that how dangerous it is to approach angry patients. So if there's say a policy that there's no cell phones or recording devices allowed, and staff members see someone on their phone or recording, how to approach that, not immediately trying to grab their phone or to yell at them, but kind of the starting out softly and then escalating if need be. But it's just really dangerous to immediately go in kind of with a trigger reaction. And de-escalation training is imperative. Some of the most common techniques, of course, just remaining calm and respectful, try to step away from an argument instead of getting dragged in, and honestly just walk away if necessary, and keeping your voice low. And these are just some of the more obvious suggestions to de-escalation. There's entire courses on de-escalation. Some of you may have even taken a course or have someone come in to train your staff. And I would highly recommend that because, again, this is a topic that is best taught by a real expert in de-escalation techniques. And it's really, really helpful, particularly if your practice is in an area where you might not have security close by, or maybe you just live in a high, or excuse me, if your practice is in a higher risk area. And encouraging staff to report disruptive behavior at any time, that's so important. Going back to one of the first slides where it said that, a certain amount of these incidents never get reported. That's just so, it's tragic that we don't really have the accurate numbers about how big a problem this is. So encouraging staff to report concerns and just emphasizing it's really better to over-report than to underreport. Even if they're not sure if something falls into this area, encourage them to report it. Of course, you need to make sure that they know how to report. If you have an electronic incident reporting system or on paper, no matter what it is, making sure they know how to access that reporting system. And letting staff know, what to expect during a situation. And this applies to everyone from front office who has to deal with a lot of this all the way through the back. And practice. It's really important to do mock drills. And I'm not talking about just an active shooter situation, even though it is important to have a drill for that. I mean, I know my daughter did in school, which is still kind of horrifying, but I mean, I think it better prepares everybody for that situation. But you can do mock drills just for a difficult patient encounter that appears to be escalating, and who does what, say in the active shooter situation, just going from calling 911 to how to get out of the building, the safest routes that I had mentioned earlier, and know when there's a potential trigger, say if a patient is being denied pain medication or disability paperwork, those type of things, to be really on guard during those situations. And lastly, I did want to mention discharging a patient from a practice because of behavior. Of course, we always recommend trying to remediate a patient, whether it's having them sign a behavioral contract, talking to the patient, whatever it may be. But there's times when if all else fails, the patient needs to be discharged from the practice. And I know, speaking to some practices, they have this procedure down pat. Some really hate to discharge a patient, particularly I do a lot of work with federally funded community clinics, and they're sometimes the last resort for some of these patients. They're the safety nets, and they don't like to discharge patients. But I go back to that duty that a practice administrator and physicians have to keep themselves safe, and more importantly, of course, the patients and staff safe. And so discharge needs to be seriously considered when a patient there's escalation and you think that a patient might cause harm. And I know the general rule, we always say you have to give patients notice. Usually that's 30 days in order to find a new physician. But if a patient is threatening, being violent, then there's times when immediate termination is warranted. You don't want a patient who's threatening to shoot everybody and say, okay, well, here's your 30 days notice. No, that just it doesn't work there. There are times when you can immediately terminate because the balance between facing a charge of abandonment versus dealing with a horrible situation, a violent situation in your practice, it definitely, our lawyers always say they would much rather defend an abandonment claim than the other. And I do urge you, I mentioned our risk management helpline. If you are a ProAssurance insured, then we're available to you free of charge, part of your practice. So you can always call us and run a situation by us. Sometimes we'll help you out, or there has been times when we've gotten our claims department and an attorney involved as well. And our number is at the end of the webinar, and I think you were already given a copy of the slides, but our hotline number is at the end. And so before I go into some risk reduction strategies and to how to reduce the threat of workplace violence, I'm going to play Dr. Lajanu's clip about where she shares her thoughts of prevention.
Had we put in a locking door, some kind of security measure to prevent that patient from being able to come into the office, had we had a plan where when there was a threat like this, there could have been an all-page sent out with a code, code purple, whatever, that everybody knows, okay, time to either hide or run, one or the other. The training of what do you do once it has crossed the threshold of this is going to turn violent? How do you hit the all-page? What kind of code do you use so that you don't panic the patients, but everybody who knows what code purple means is like, okay, you and I, we're going here, and get patients out of harm's way. Where the exits are, which exits are safe exits to use that will lock behind you that you can go away, which exits lead to dead ends in a hallway that you can't get out of. That kind of thing I think is worthwhile. Having locked doors is important, I think, because for a lot of reasons. One reason is simply the privacy of the patients. If you've got an unlocked door and somebody can just breeze in and walk back and say, hey, I forgot to mention such and such while you're talking to someone else, that's not good. That's not respectful of anyone. On top of that, if you've got the locked doors, you can prevent someone like that from easily getting in. Somebody who's determined can get in, but if you've got the locked doors, and you've got the all-page, and you've got a plan, you can mitigate the situation.
So you can see from what she was saying, the various recommendations that a common theme in all that is training and making sure staff knows what to do. And that's why I've mentioned training in several areas. I was probably going to mention it again, but you can see how important that is in this the umbrella of workplace violence prevention. That's the staff training aspect of it. So let's talk about developing a plan and a workplace violence prevention plan. And whenever possible, I know I had mentioned getting the buy-in of physicians and administrators, but getting employees involved as well. They're oftentimes those people on the front line and can, I think, be very helpful in developing a plan and giving their input about what they go through. And if you get them involved and you make sure that leadership is involved and dedicated to providing the support and the resources, and this just goes a long way to making a successful plan. And this is important whether you're part of a really large practice or you're solo. It's always important to have a plan that fits your particular circumstance. Assess what you currently have in terms of security, cameras, alarms, locked doors, lighting, maybe mirrors at blind corners. See what you have and what you may need. And then another important part of the workplace analysis should be knowing the crime rates in your area, the crime statistics, because it really will affect how extensive your plan may need to be. Do you have, do a physical assessment outside the office and all types, all areas, including entrance ramps? How do people get in? What's the access? Do you have access to security? Like I mentioned before, if you're near a hospital, well, security will be able to respond. Those all go into that initial analysis and development of the plan. Imperative to have policies and procedures. I know in risk management, I feel like I'm always preaching about policies and procedures and making sure that everyone's aware of them. But all policies should include just a really straightforward definition of what is workplace violence. And again, it's not just physical. It's not physical violence. It's any type of verbal harassment, threats, all of that should go into it. And then have a very kind of a strict prohibition against any of that conduct. You clearly lay out what conduct is prohibited. And the policy should explain staff members' responsibility. Like we talked about, who's responsible for doing what during a potential workplace violence situation. And lastly, a strong policy indicates how to report an incident, where to locate the form, and help encouraging that important staff role in reporting in order to maintain hopefully a culture of safety. So whenever an event occurs, it's important to debrief staff as soon as practical. So usually this can occur, I mean, it can occur right away, but it should occur within, say, 24 to 72 hours after an event. And this post-event management, and it also could include employee assistance, a program to support staff depending on how bad the incident was. And as with any event, that any unusual outcome or bad event, the use of quality improvement measures are important, kind of like a root cause analysis that you do in a hospital, and dig down to see what worked, what didn't work, and what can be improved. Looking at what measures you currently have in place, and do things need to be refreshed? And does training need to be? Do you need a refresher on training and doing more drills just to prevent something like that from happening again? So it's important to remember the cost of violence, and of course there's the huge physical and more emotional trauma that can happen. But just from the purely operational perspective, this can create, if someone feels they're unsafe in an environment, and create turnover, potential workers' comp issues if someone's injured. And then not to mention, as I mentioned at the very start of the presentation, the potential legal aspects, the legal proceedings that could occur if staff is injured or patients are injured and feel like there weren't appropriate measures in place to take care of them. I mean, of course, not everything can be prevented. We all know that. So it's really just taking reasonable, that word is big in the law, and especially in the area of like medical malpractice and these types of situations. You have to take reasonable measures to prevent something like this from happening. You cannot prevent everything, but if you take reasonable measures, then that really helps our defense attorneys in defending a case such as this. And I know I've mentioned training ad nauseum, but I just want to have these bullets here just to kind of summarize and to further emphasize the importance of training. And these are some of the things that you'll want to work with your staff with, just kind of a nice summary of the things that you're going to want to hammer home during employee training. Record keeping. So this is so important, not only just for, I mean, it's obviously the law requires it in some situations, but you can also use it to analyze and look at the current things you're doing right and implement some violence prevention strategies. And I had mentioned about staff filling out reports, using those to look at trends, to look at, you can look at patient complaints, and communicating back around to staff if they are filing these reports, if there's any follow-up. I know I learned from nurses working at the hospital that nothing is more disheartening than taking the time to fill out an incident report, and then it would just seem to go into this black hole and nothing would change. You never hear anything about it. And of course, that will just discourage further reporting, and then the whole thing is just pointless. And so that follow-up back to staff, particularly if you're seeing trends and taking some type of action and then following up and making sure communicating with staff. It's something maybe that can be shared at staff meetings, just to let them know that you are hearing them, you're listening, and if appropriate, you're going to take some proactive steps out of those. Just briefly want to mention communication with law enforcement and the media. If whatever happened rises to that level, that they will be involved. And you want to let staff know who the designated contact person is. Usually it's a lead physician or administrator, and they will handle all the requests for interviews. You definitely don't want staff to have to deal with that on their own. And having updated personnel files with contact information and backup numbers, just in case you need to be able to get a hold of people quickly, having that uh, updated and accurate. And the chain of evidence, just like if an unfortunate event, say, happens in the operating room and you want to save the anesthesia settings and all the equipment and everything, preserving evidence in an incident, particularly if it involves weapons or firearms, drugs, just save all of that until law enforcement's involved and they can handle it. And same thing with getting witness statements, victim statements. If it rises to the level of law enforcement being involved, then they will handle it. And of course, just remembering to follow HIPAA privacy rules. There's times, of course, when you give out patient information, particularly if a patient was a perpetrator, but it really comes down to what is minimally necessary and providing the information that would be helpful to law enforcement. And one thing, kind of the last area that I'm gonna talk about is proper management of a workplace violence. It's not a one-time thing. It involves ongoing monitoring and of prevention strategies, what's working, what's not working. And as I mentioned, analyzing the incident reports, the patient complaints, do that regularly and you want to see if there's a risk of escalation or potential violence, following up and taking appropriate steps whenever necessary. And this is just it's really a comprehensive approach, and it includes using like the appropriate techniques with patients that you can learn in a training. For example, do you have a checklist for receptionists when a patient walks through the door? And these are just little things, but they make a big difference. And do they introduce themselves? If you're running behind, if a physician's running behind, do you keep them updated so they don't get frustrated just sitting there? If patients are going in ahead of them, keeping them up to date as to what's going on. And have you provided, front desk staff might need a script to address if there's, say, a potential bad situation and how to address that concern, knowing when to stop and go get help in the back, go get a physician or go get the practice manager. Because sometimes that's what it takes if a patient's really upset. And again, as I mentioned earlier, they tend to be a little bit more aggressive and upset with frontline staff. And so just showing them that, okay, you care and you're concerned, and so you're going to go get a practice manager to address it or go get a physician. Those types of things, those small things can just play a large role in reducing the number of upset and disruptive patients. Oops, sorry, my computer froze just for a second. So those are some of the main techniques. Again, I can't emphasize enough getting help, getting training for your staff to come in and do these mock drills, because that just really helps so much in preparation. So I'm going to play another video clip this is Dr. Greg Jackson, and I believe he's from Texas, but he's a proponent. He's dealt with, in his career, violent situations, and he just is going to talk about some closing thoughts on workplace violence prevention. And he just really sums up well some of the things that we talked about today.
Violence in the workplace, often unpredictable, most of the time random. It's happening more and more often. It's necessary to talk about it. There are programs designed to help workers deal with escalating violence in the workplace. Workplace violence is defined as any act of threatening or violent behavior, assault, harassment, intimidation, threats, disruptive acts occurring in the workplace. I remember specifically a time when I was a resident. I was in Houston, Texas, in a county hospital, and one of the residents had a patient who pulled a gun out and pulled the trigger. Thankfully, the gun misfired, but it devastated the resident, and I'm sure that he's still having to deal with this. Was this preventable? Absolutely not. But we're seeing it more and more often, perhaps in emergency rooms. We're seeing it in mental health care facilities and home health care facilities. We see it where patients have had to wait a long time and develop a lot of anger in the emergency room. All we can do is educate our staffs, educate them about identifying patient behavior, looking for assaultive behavior, escalating violence, perhaps anger, and learning methods to diffuse it. You have to look for mood instability. You have to look for hostility, perhaps patients that have a history of head trauma, mental illness, perhaps they've been abused. Let's consider risk factors. Prevalence of handguns and other weapons. Remember, it's legal to carry weapons in some states. Increased use of hospitals by police for placement of acutely disturbed individuals. Patients' rights to refuse medications and hospitalization unless they pose a threat to themselves or others. Hospitals, clinics, pharmacies, all easy targets for robbers. Frustration and anger due to long ER waits. Often there's unrestricted movement through clinics and hospitals. Inadequate staffing or security in facilities. Lack of backup in high crime areas. There's lack of training in recognizing and managing escalating and hostile assaultive behavior. Employers can establish a zero tolerance policy. Secondly, they can train their employees to recognize assaultive and aggressive and potentially hostile behavior. And thirdly, they can implement policies to mitigate risk. At the end of the day, you have to understand your patient. You have to learn how to diffuse anger by listening to their family, speaking slowly and calmly. And finally, you have to exercise common sense and stay alert.
Well, I know this topic is serious and depressing, and I hope I haven't left all you very depressed on this lovely Thursday afternoon. But the good news is, even though not everything is preventable, there's lots of steps that can be taken to be prepared and to prevent something like this from happening. These are just two of the resources that I found that are easy to access. ASHRM, the American Society of Healthcare Risk Management, they have, they call it a toolkit, but it's really, when you click on the link, it's really more of a checklist that covers all the areas that you should be looking at and taking care of. And OSHA has a good workplace. They have a whole website devoted to healthcare workplace violence and lots of good resources there. And these are just a couple of the resources that are available out there. If you just do a Google search, I think you'll be able to find a lot that can help you in all these areas, the training, the working out a violence prevention plan. Luckily, there's lots of things available out there, lots of resources. And these are just some of the references that I used for the presentation today that you can, in your spare time, if you choose to, you could click on the sites there and take a look at those articles. And lastly, just thank you very much for joining me today.